Welcome, clinical problem solvers. Today is our international VMR, and we are very excited to be here. So today I will be scribing, and we hope to see a great case today. So let's go ahead and Chiara, can you present yourself?
Yes, so hi friends, I'm Chiara. For all you who don't know me, I'm a medical student from Peru, and I'm so happy to see you today because today is special for all of us because it's International VMR, and hope we have an amazing case. We always have an amazing case, and well, Ravi.
Hello, hello. Good, happy Saturday, everyone. It's great to see so many familiar faces. Um, we are excited for today because today means that that we are going to celebrate both medicine and the fact that many people across the world come and either listen to this or hang out here with us. Um, if you have a case, please volunteer to present it. All we need today is a case. And we will try to, oh, Amanda has a case. Wonderful. We will try to highlight everybody in the chat. So, Amanda, thank you. I'll come to you in a moment to present yourself. But if you, I will tell you that as we often do, we'll try to involve the chat in the conversation. So please type away in the chat and we'll love to highlight your voice. So Amanda, please unmute yourself. Tell us a little bit about yourself.
Hi everyone. I am Amanda. I'm from Brazil. It's my first time to present a case, so if I miss something, please let me know. It's a simple case, but I like very well this case. I like very much. And this is, I'm in fourth year English in medical school in Brazil.
Amazing. Hey Amanda, so tell us what is your favorite thing to do where you're from? Like what if you had to spend the perfect day, non-COVID, everything is normal, what would you do?
To eat. I love it.
Yeah?
I'm kidding. But I love to dance, to go out and drink with my friends. I love association party.
Yeah.
Yes.
What is
And
the
study.
what is the best place to go hang out in your area?
Eat bars. I love to go to the bar. I love.
That sounds amazing. Hopefully someday in the very near future we'll be able to do that.
Yes, please.
Um, what is your favorite local delicacy, food that is local?
I love feijoada.
Ooh, what's that?
It's a black beans. It's
Yeah.
typical food from Brazil. It's very amazing.
So wait, this black beans and what else? What else is in it?
Is some special food, so meat
Okay.
and some linguiça. I don't know if you know. It's very good.
Yeah. So
Yes.
it's beans and very good is what I heard.
Yes.
Okay. Perfect. You know what? I'll just have to try it someday.
Yeah, oh, you will love it.
Yeah?
Yeah.
Yeah, I have to come visit you. That's for sure. All right. We'll have you jump on right into the case and we'll go from there. So Yabi, I know you're scribing, so take away the screen and we'll have everybody from the chat hang out. Or all right, Amanda, let's go.
Let's go. Let's go. I'm so
Oh,
excited. So let's start. We have an 8-year-old male comes to the ED with his mother complaint of abdominal pain.
incredible. Amanda, why don't we stop there? I know that's not what you planned, but I want to share something. One, I'm terrified that this is a pediatric case, but it doesn't matter because one, the patient is already very well taken care of, and two, there's a great crew here. Um, Maybe if folks just in the chat, if you wouldn't mind saying like, if you just hear this, abdominal pain, what's your next move? What would you ask next? What would you like to get next? Ooh, Gurbani, tell us more. Unmute yourself and tell us more what you mean.
This is just the mnemonic that I feel like I've learned. You can use old cards or OPQRST to take an HPI in grad school. So it's like onset, because you want to get a sense of the time course, because as you say, tempo is queen. Provocation, so like if anything makes it better. Quality, how would they describe the pain? Is it more like a colicky pain? Is it cramping? Does it travel anywhere? So a lot of things in the abdomen can travel to like your back, and to other places, and that can kind of help you figure out what organs might be affected. Severity, so on the scale of 1 to 10, like how severe it is, so that can kind of help you decide the acuity, I guess. And then time is like when did it start, I guess. Yeah.
100%. I think the time is going to be key, and the OPQRST is a great way of making diagnostic progress. The truth is, in abdominal pain in general, the history gives you a flavor of what's going on, but unfortunately, the answer is very, very far away from the history. If you study all the diagnoses, especially in adults, that we make with abdominal pain, the vast majority of them require imaging. That's because you really reflect on the pathology that causes abdominal pain is usually deep within. It's in the bowel, it's in the pancreas, something you cannot feel, see, hear, smell, etc. And so you often need to take a look inside. And I just wanted to arm you with the rule of twos, and that is that there is no way you can make a diagnosis on history. There are only 2 diagnoses that you can make definitively on exam, 2 diagnoses you can make definitively on labs. So my teaser question to you all is, what are the 2 causes of abdominal pain you can diagnose with certainty on exam, and what are the 2 causes you can diagnose on labs? And as we think about them, I'll ask Amanda to give us more information as this case evolves. But the big learning point is most abdominal pain, you have to take some sort of picture to understand what's going on inside. And the only time that you can avoid doing that is when, 1, you don't think you need an answer because the syndrome is benign, or 2, you get an answer on exam, of which there are 2, or 3, you get an answer on labs, of which there are 2. So think about that, and I'll pass the mic back to Amanda.
So, reports diffuse abdominal pain that started 2 days ago and has been worsened since then. In the last 2 days, he also had polydipsia and polyuria. He also had 2 episodes of vomiting and out blood or mucus or pus last night. He denies fever, caries, and any infection or symptoms of diarrhea. He lost 9 kilograms in 2 days, or his mother is not sure if he lost weight.
Incredible. Awesome, Amanda. This is a great place to stop. Perfect. Hey, folks, I'm going to ask for somebody to volunteer to share how they think about polyuria. So I see a couple people. I see, Marcella is agreeing. Wonderful. I know Drew knows this because we talked about it last time. So Marcella, do you want to unmute yourself and tell us what you were thinking?
So now I'm thinking that this patient probably has diabetes because he has the classic symptoms, so polyuria, polydipsia, and the abdominal pain. I am worried that his blood sugar is too high now, and he's having, oh God, what is the name in English?
You can say it. You can say it in Portuguese. It's okay.
So yes, ketoacidosis in Portuguese would be cetoacidose.
Can you say it again?
So I am thinking about that.
Amazing. How do you say it in Portuguese again?
Cetoacidose.
Acidosis.
It's
Amazing.
close.
Close. Thank you. Thank you. Thank you. Thank you. Kanu has a great approach to polyuria. Kanu, do you want to unmute yourself and share it, please?
Hello.
Oh.
So when I think of polyuria, I like to think of whether it's an osmotic cause or a non-osmotic cause. When it's osmotic cause, I like to think whether it's because of, when we say probably increased glucose, increased urea.
Yes.
And non-osmotic causes, I'd like to think of diabetes insipidus and psychogenic insipidus, which can be further confirmed by water deprivation tests. That's my approach.
Brilliant. It really is brilliant. And I think you can, in a non-hospitalized patient, you can make it even simpler than the fantastic approach you had, which I'll share with you. If somebody's peeing a lot, they either are drinking too much water or they have diabetes. It's that simple. They're either having psychogenic polydipsia, or primary polydipsia, or they have diabetes. The diabetes that they have may be mellitus or insipidus. You don't know that, and that's when you need a serum glucose to help you figure this out. And if the serum glucose is normal and they're not drinking too much water, again, which you can figure out with a water deprivation test, they have diabetes. In a hospitalized patient, as Kanu mentioned, you have to worry about other hyperosmotic agents like mannitol. But in a person who's coming from outside the hospital, if they truly have polyuria, then you worry about them drinking too much water or them having some kind of diabetes, either mellitus or insipidus. I'll give the screen back to you, Gabby. But let's be practical. The practical point, unfortunately, is that it's very hard for people to distinguish urinary frequency from polyuria. It's hard for all of us when we're urinating a lot to know, are we just urinating small amounts frequently or are we urinating a lot? So often the approach to polyuria is study the possibility that it's actually urinary frequency, low volume, and then work up polyuria. But if somebody from the world is coming with polyuria, it's either they're drinking too much or they have some kind of oh, perfect. I just seen Nilan, you're making this point. Can you share your experience on it, Nilan? I think we lost him. Nilan, are you there? Oh, I see you're unmuting yourself, but we can't quite hear you yet. Maybe there's something with your mic. It's okay. I'll read out what you said in the chat. Nilan was essentially saying it's really important. Oh, there you are. I see your video, but we can't hear you yet.
Hello.
Oh, there he is. Yeah. Hello. Good evening.
Hello. So I missed your question. I lost the net there.
No, that's okay. Can you just elaborate on the point you were making in the chat, my friend? You were talking about bladder irritation. Just to elaborate on that.
Yeah, so I think you covered on it at last. You said something about bladder frequency, urinary frequency versus urinary volume, and that's just the point I was trying to make. Like if the patient complains of increased frequency of urination, then it's probably not polyuria. That's more like bladder irritation, and that is less likely to be associated with polydipsia. But if the patient is complaining of polyuria, that is large volumes of urine, then the patient is actually losing volume of, then the patient is actually losing water, and that is more likely to be associated with polydipsia.
Brilliant. That is absolutely brilliant. I have nothing to add to that, and I'm glad that is now up there for folks to reflect on. Perfect. Okay, let's go back to what we were talking about. We have, as Drew was alluding to, we now have one possible diagnosis we can make with labs. And let me share that with you. So remember, abdominal pain is all about getting an image unless you are lucky enough to encounter the rule of twos. And the rule of twos is the following. So you can only make 6 diagnoses of abdominal pain before you get CT scan. You can make no diagnosis on history, and these are the highest yield history questions from a diagnostic perspective. The 2 things you can make definitively on exam are as a hernia or zoster. The two things you can make definitively with bedside tests are an EKG, inferior myocardial wall infarction, or to get a post-void residual for which urinary retention may be diagnosed. The two labs are lipase and hyperglycemia. This is always tricky because you always have to make sure that there isn't something else going on in the abdomen, like pancreatitis causing DKA, or like diverticulitis making DKA worse. So this is a plus minus. But the rules of two, sorry about that. The rules of two are 2 on exam, 2 on bedside test, and 2 on labs. But all other, you either need a CT, ultrasound, or something to help you make progress. Questions about that? All right, sorry, I lost the chat. I'm gonna, man, sorry about that. Okay. All right, Amanda, why don't you give us more information?
So he don't have no past medical history or meds, no allergies. His father and mother are healthy, and his grandmother has diabetes. Let's go to the exams. To the synovials. So his temperature is 36. His heart rate is 108. His respiratory rate is 35. BP is 10/8. And his SpO2 is 79.
Wow. So is it 100/80? Is that what the blood pressure is?
Yes.
And his oxygen is only 79? Oh,
9.
wow. Okay.
So, and in the exam is where everything is normally without change. Just in abdominal system, we have some change. His abdominal is flat abdominal, decreased bowel sounds, diffuse pain on deep palpation. In the respiratory, we have tachypneic, normal breath sounds without cracklers or wheezing.
Whoa. Wow. I cannot believe he's satting only 80%. Amanda, did you give him oxygen?
No.
Okay. Well, you know, just looking at the chat real quick. You know, it's not surprising that when somebody has abdominal issues, it's not surprising when somebody has abdominal issues that they have some breathing issues. And the connection between abdominal issues and breathing issues often is mechanical. So if somebody has ascites, they can have atelectasis from that, and then they develop hypoxemia. It was hard with polyuria and polydipsia not to have a working diagnosis of DKA, and the mechanism of shortness of breath in DKA or tachypnea in DKA is metabolic acidosis causing respiratory compensation. And so here, we are in a world where now we're worried about the belly, but the hypoxemia tells us that there's something going on in the lungs as well. The simple explanation of DKA causing metabolic acidosis causing tachypnea does not account for the hypoxemia, because somebody, when they're short of breath just from blowing off CO2, should not have a low oxygen. Because of how surprised we are about that low oxygen, because his lungs are clear and he had no symptoms, you have to step back and be like, is it a true reading? Is it because there's something in the way? Is there nail polish, or the O2 meter is wrong, or he's actually has soft blood pressures and the O2 reading is incorrect? So we were all going down this world of abdominal pain. Do we need to CT scan it? And now we're getting a sense that there's actually something wrong in the lungs. And that something wrong in the lungs has to be reconciled with the fact that the X-ray, or that the exam is normal. The truth is the stethoscope is not as good as the chest X-ray, is not as good as the CT scan, but you have to start to wonder, does this person have something that will not show up on imaging, not show up on chest x-ray, not show up on a regular CT? And those are things like an intracardiac shunt or a pulmonary embolism. But I think the next step is to now change the problem. The problem is lung plus belly. And I'm going to stop there and scan the chat. And actually, Vijay, you were mentioning cyanosis. What prompted you to ask that question?
Given that the saturation is so low, we expect some amount of hypoxemia causing some amount of cyanosis to happen. Either it could be like you said, because the lung exam, physical exam is clear. Either it should be a shunt, or is it a peripheral cyanosis that we are not getting?
Wonderful. That is a brilliant way of trying to verify the accuracy of this O2 sat. Amanda, was he blue anywhere? Was he blue in his face, his fingers?
No.
No. 3 no's, not just 1. Okay. All right. And I see Kushal teaching us about lung plus GI. Kushal, tell us more, please.
Yeah, I was surprised by the pulse ox, and I agree that we need to make sure that there is it's not an artifact from nail polish or something like that. But when I thought of lung plus GI, I thought about Legionella, and maybe we'll see if patient has hyponatremia or signs of rhabdomyolysis that would be indicative of that, or any consolidation on the X-ray. But yeah, even Legionella seems kind of shaky right now, so we'll see what the case progresses.
Incredible. I absolutely love it. Thank you so much, Kushal. Dhruv, do you want to tell us more about your problem representation and what you learned from this New England Journal article?
Sure. So I guess to start with the problem representation, we have an 8-year-old boy with not very significant past or history of anything, presenting with diffuse abdominal pain, polydipsia, polyuria, and found to be markedly hypoxic and tachypnic on exam. And just to go off of the points that were made, like with the pulse ox, so there was a recent New England Journal article, and actually it got back into prominence recently because there was a very, very ignorant letter to the editor that was written in response to it by Jack Iwashina et al. That essentially talked about how pulse oxes tend to underestimate, I'm trying to remember if it was under or overestimate oxygen saturations in patients with darker skin. And it's one of the big examples of systemic racism in medicine, that these machines that we trust to be able to get an accurate picture of how well oxygenated this patient is are fooled by just darker skin.
Absolutely brilliant. I think if we can, I'll try to find the link for that article. It really, really was a game changer for me too. And I think reflective of so many lessons we're learning about how we've studied things and applied data in medicine. So thank you so much, Drew, for sharing that and for a great problem representation. Marcella, I see you're invoking a combination of lung plus abdominal stuff. So can you tell us what you were thinking in the chat?
So I was thinking that maybe we have 2 things going on, but not separate because they can be related. Like Drew said before, the infection could be precipitating the Dka. So I was thinking about that. So Dr. Ekan, yes.
Beautiful. I love that. Marcella, I'll ask you in a moment just to maybe give us a summary of the problem representation in Portuguese. Is that okay? Just in one moment. In the meantime, I'll ask Kanu to tell us more about methemoglobinemia.
So there was a mention of cyanosis with this low hypoxemia. So I was wondering, I mean, it's not really in the case, but was sharing that methemoglobinemia usually has saturation in 80 to 85%. That's like the constant level that's seen in methemoglobinemia. So it's usually because of the reduction in the hemoglobin levels, but they do not decrease significantly. There's something called, I think, saturation gap of about 10 to 15%. That's usually said in the diagnosis of methemoglobinemia. I've seen a couple of cases, so I just wanted to share that.
I think it's brilliant. That's a really, really good thought. And what methemoglobinemia does is it messes with your pulse ox to make it read something like a SAT between 85 and 90%. But when you actually get an ABG and look at the PaO2, you'll see the PaO2 is actually pretty high, but the SAT is only showing up at 85 or 88%. So that's what the saturation gap is that Connie was saying so well. Marcela, are you ready for a problem representation in Portuguese?
Yes, and I think Debbie already helped me, so let's go.
Good.
Então, até agora, nós temos um menino de 8 anos, previamente ígido. Ele se apresenta à emergência com dor abdominal e vômitos há aproximadamente 2 dias. E ele também tem uma queixa de poliúria e polidipsia, assim como uma perda de peso nos últimos dias. E no exame físico, a gente percebeu que ele está com uma saturação preocupante de 79% de oxigênio, o que até o momento faz a gente questionar se está acontecendo 2 processos diferentes ou um só e por que estaria acontecendo. Yeah, that's it.
Thank you so much. All right, perfect. Amanda, do you want to give us more information?
I love it.
Oh, Amanda.
This sounds about Portuguese.
Before you tell us more, I see Hernan has a problem representation in Spanish. Hernan, do you want to unmute yourself and say it so the people listening can hear it too?
Hi, everyone. I'm from Chile. Problem representation in Spanish would be like this. Niño de 8 años, sin antecedentes significativos, con una historia de dolor abdominal, polidipsia, poliuria y con desaturación severa de 79%.
Oh, that sounds so beautiful. Thank you so much, Hernan. And since I think this is the first time we're hearing your voice, tell us more about yourself, please, Hernan. Where in Chile are you calling from? Tell us more about who you are.
Yes, I'm from Concepcion, that is a south region in Chile. And I'm an internist. I'm head of the internal medicine department at my hospital. I'm also a teacher in University of Concepcion. And I'm a very fan of diagnostic process. It's like my obsession. So it's like very amazing for me.
Yeah, you and me both, my friend, you and me both. Outside your obsession for diagnosis, what else do you enjoy doing?
I enjoy very much for music. I play guitar, a little bit of piano. I like to sing very much.
Ooh.
So
I'm going to ask you to sing the problem representation if that's okay. Wonderful. It's so nice to meet you, Hernan. Welcome to the VMR community. It's a delight. And maybe in the near future, we can count on you to play some guitar live for us right here.
Okay, no problem.
Thank you so much. All right, Amanda, give us more, please.
Let's go. So in the exam, we have RBC 4.59. We have a hemoglobin 12.2, MVC 8.1.7, MCH 28.5, platelets 200,000, WBC 12,000, so ROT 3%, neutrophils 7%, lymphocytes 20%. More?
Amanda, the neutrophils were 70% or lymphocytes 70%?
Neutrophil, lymphocytes 20.
Okay, thank you. Yeah, maybe just the rest of the labs.
Okay, we have, so if I give you the others labs, we have a diagnosis.
Oh, okay. Then maybe just a chest X-ray for hypoxia. Do you have that?
No, I have some labs like sodium. I have 131, potassium 5.5, chloride I have 95, urea 70, creatinine we have 1.3, and glucose we have 595.
All right, this is actually very, very helpful. I think, trying to see if there are thoughts trickling in the chat. Hyperglycemia. Hyperglycemia here is, I think, going back to Kanu's approach. Is there an osmotic diarrhea? Now we found an answer to the polydipsia and polyuria, and the hyperglycemia is almost certainly driving the polydipsia and polyuria. The key question is why? Why is this patient hyperglycemic? So Kanu, tell us more about what you're thinking so far.
After seeing these labs on the CBC, there's definitely signs of infection because neutrophils are also elevated. Apart from that, the chemistry labs are certainly significant. I will just start from the renal function test. First of all, like urea and creatinine are elevated, and urea creat ratio is more than 20. So that's a sign of renal failure. Glucose is elevated at 600. So that's certainly significant. It can be DKA or hyperosmolar non-ketotic coma, but I'll just wait for the keto acids for that. Apart from that, hyponatremia is usually common, and it's usually pseudo-hyponatremia because the elevated glucose levels tend to fluctuate in the calculating machines, and the levels fall. So if you correct that, it's certainly normal. The potassium of 5.5, I like to think of it as a pseudo elevation, just because the total body potassium is actually decreased in these patients, but it tends to overshoot in the labs. So that's my thought process. I'm just waiting for anion gap and bicarb to confirm the diagnosis. But apart from that, I will start to resuscitate the patient as soon as I see these labs, actually.
I think that, the abdominal pain dimension is getting more clarity. We have hyperglycemia here, and we have hyperglycemia in a young patient. So I think it's probably a fair assumption to say that in a patient who is young, they are more likely to have type 1 diabetes than they are to have type 2 diabetes. Now, why is that distinction important? DKA and HHS are two very different diseases. I'm going to pull up a little comparison to talk about them briefly. But we don't know this yet. This is all under the grounds that we're going to get acidosis, but it's a good place to start. So what is the difference between DKA and HHS? Fundamentally, the difference is how much insulin is there on board. Both of them, both DKA and HHS, represent an excess of counter-regulatory hormones compared to insulin. In DKA, there's absolutely no insulin around. There's complete inaction of insulin, versus in HHS, there's enough insulin around to do one thing. What's the difference between zero insulin and low insulin? It's the ability of ketone formation. When there is no insulin at all, you start to make ketones. Even low amounts of insulin suppress ketosis. Now, what does that do? The ketones, when they develop, very quickly cause abdominal pain, nausea, and vomiting. And so patients with DKA tend to present pretty early, and they tend to present with abdominal pain, nausea, and vomiting. In contrast to patients with HHS who have a low amount of but still effective insulin, these patients don't get ketosis, so their glucose tends to be higher and higher and higher and higher compared to the minimal elevation in glucose here. And that results in volume contraction and encephalopathy, but no pain, so they tend to present later. And as a result, their morbidity is higher. These patients die and have much more problems than these patients simply because they present later. The treatment is very similar, but the important thing is to look for why. Why is this person who had diabetes yesterday, 3 days ago, 3 weeks ago, why do they have this problem today? And that's the 7 I's. 7. You have a lot of work to do. You have to make sure that, as Marcella told us, they don't have an infection, they don't have ischemia, they don't have inflammation, that they don't have an ingestion, that they don't have an infant, they don't And then if you do all that, then you're probably down to here. Either it's their initial presentation or they're not able to take their medications. So I'd encourage you to know that most hyperglycemia is not DKA or HHS. Most hyperglycemia is suboptimal long-term control. But if you are in an acute crisis, you either have DKA or HHS. What's the fundamental difference? The fundamental difference is the lack of insulin in DKA causes ketones and causes patients to come much earlier. HHS, no ketones, present much later. And look for the 7 I's as the trigger. The bottom line, though, is what does it fundamentally mean to have no insulin? It means that you have a deficiency in secreting insulin, okay? Because insulin resistance, the driver of type 2 diabetes, usually doesn't cause complete absence of insulin, though it can in very late stages. So from a diagnostic perspective, right now, we have to look for the trigger, but we also have to wonder what the cause of diabetes is. So why does this patient have diabetes? And the complete lack of insulin prioritizes these causes. Now, in kids, the most common is type 1 diabetes, which is an autoimmune destruction of the pancreatic tissue, but there are other causes of insulin deficiency, and that can be some genetic causes, or in adults, a variety of rare causes like pancreatectomy for pancreatic cancer, hemochromatosis, IgG4 disease, pancreatic cancer. There's all sorts of things. In a kiddo, you don't have to think much beyond this. But if you have new insulin deficiency in an older adult, there's a much wider DDX, including these things here. Okay, so I'm going to stop. I'm going to take a look at the chat. Dhruv, I see you're making some really interesting points here. Do you want to expand on them, if you don't mind?
Where do we start? So I guess the first thing that I can start with is his BUN and creatinine are a bit high. I'm not sure, I think the urea, is the urea in the units that we use here in the States? I'm trying to think. But regardless, those units are probably high because this child probably has not had fluids put in him. So the standard practice, at least for DKA protocol in our hospital, not sure about others, is normal saline, I think, is the typical fluid of choice, although there's been a debate about whether or not lactated ringers can be used, especially if you have potassiums that are not terribly high. And then you immediately start an insulin drip. You can also, at our hospital, we also tend to start long-acting subcutaneous insulin, so something like an insulin glargine or insulin detamir, just to have that long-acting insulin on board and reduce reliance on the insulin drip. The second thing was that HHS glucoses tend to be very, 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 very high, like in the 1000s, and I think the world record is like 2,199 or something like that. And HHS treatment usually starts with aggressive fluid resuscitation first, and insulin can come later. And usually the treatment is you give fluids until the glucose stops dropping, and then you start insulin. And here in the US, I don't know if this is practice in other countries, but anyone who presents for their first time in diabetic ketoacidosis typically goes to the ICU first, because that's sort of a hospital, it's sort of hospital dependent. But very mild cases of DKA can actually be treated at home. As long as you have very, very, very close follow-up with an endocrinologist. And for this patient, since they're 8 years old, again, this is type 1 diabetes until proven otherwise. And if they were in the US, the next test for this patient would probably be the type 1 diabetes autoantibody panel. So there's GAD65, trying to remember the zinc transporter protein that's that there's an autoantibody for, and then anti-insulin and anti-islet cell antibody.
Perfect. Thank you so much, Drew. Amanda, do you want to give us the final data?
Yes, we have a venous pH is 7.9, PO2 is 56, PCO2 is 19, bicarbonated is 9, and we have a urine exam. It's normal, just 2 elements change that are glucose, 3 cruces, and ketone, 3 cruces.
Okay. Can I ask, the pH is 6.9 or 7.9?
What? Repeat, please.
The pH, what was the pH?
7.9. 7.9.
Wow, that's higher than I thought. 7.29 or 7? Huh.
7.9. I'm writing here in the chat.
Is that high or low, Amanda?
It's high.
Huh. Can you tell us how you were thinking of that?
No. I wait.
Okay.
It's low.
What's normal?
Well, it's 7.35 and 7. Yes,
No,
here in the chat.
so his
It's
pH.
low.
Oh, 7. Oh, okay. Got it. And I think for Gabby, it's 7.09. Okay, perfect. Woo! Thank you, Amanda. Okay, so and do you have the bicarbonate, Amanda? 9. Okay.
Yes, 9.
Amazing. All right, my dear friends, we have an acid-base problem before us. If you are in the chat, I'm gonna just call on people I know and love. I know and love everybody here. But who wants to go through the acidosis? Oh, wait. So somebody is I feel like somebody is volunteering. Valeria, do you want to walk us through what you're thinking with the acidosis? Got picked on. Unfair.
Yes, I mean, I'm kind of yes. So the acidosis makes sense in this scenario. We are expecting ketoacidosis, just because of the excess of ketones.
Yes.
And we will also expect a high anion gap, which is, something that we don't see, acidosis and high anion gap in cases of hypersmolar state. That could also happen in case of diabetes. And yeah, I think it makes sense for this patient that has the clinical presentation. Sorry, I'm a little nervous. You kind of put me on the spot with this question.
Because I know you can crush it. You did. That's 100% true. When you think about the pH being low, the first question is it metabolic or respiratory? And here we see that the PCO2 is low and the bicarb is low, so it has to be metabolic. So this is a metabolic acidosis. And then the next question, is there a gap or is there no gap? And here I see there's an anion gap, though I'm not going to do any math, but I see that the anion gap is, who's going to, I can't do the math. 130 minus 95 is 35. The anion gap is, what's the gap? Is, yeah, about 25 or so is the anion gap. A normal anion gap is about 13, let's say. So the increase in the anion gap, it went from normally 12 to 13 to 25. So the change in the anion gap is 12. And the question is the change in the bicarb similar? The bicarb went down from normal of 22, 23 to 9. So that's a change of about 14. And the change in the gap is similar. So this is a pure anion gap metabolic acidosis. So let me walk you through that. The pH is low. And the question is it respiratory or metabolic? The respiratory, the PCO2 is low and the bicarb is low, so it's metabolic. And then the question is it anion gap, non-gap, or both? And that's when you look at the anion gap, you see it's 24, but a normal anion gap is 12. So the anion gap opened up by 12, And what happened to the bicarb? The bicarb went down by a similar amount. So this is a pure anion gap metabolic acidosis. So I'll ask the chat, my dear friends in the chat, what the differential diagnosis of an anion gap metabolic acidosis, and you'll say 10 different mnemonics. I will tell you, oh, Kanu has shared one really famous one, the gold mark. I'll tell you, gold mark is amazing, but I'm going to make it simple for you. There are three very common ones. There's ketones, lactates, and uremia. Ketones, lactate, and uremic disease. That's really the most common. And here we see ketones. Ketones are probably accounting for this gap, but let me show you a simple way of thinking about anion gap metabolic acidosis. So this is a little, you can have your favorite mnemonic, but you really have to know one thing. You have to prioritize lactates, ketones, and the U's, sulfates and phosphates. These are when your GFR is lower, you have rhabdo. And then you can use either endogenous causes or exogenous causes, and these are the ones we worry about a lot: methylone, ethylene glycol, salicylase, etc. Why do we make this distinction on the clinical problem solvers? We do that because these are ones where the osm gap is also elevated, and these are ones where the osm gap is normal. So if you have an anion gap metabolic acidosis, the next question is there an osmolar gap as well? And I'd really encourage you to listen to the podcast episode, the Clinical Problem Solvers podcast episode, where we explain this concept in more detail. But the base rate would tell you that you should look for lactate, ketones, get a creatinine, and get a CK. That will answer your case of metabolic acidosis in 95% of patients. And if you have an osmolar gap, should you worry about the accumulation of exogenous toxins like the toxic alcohols or like salicylates, valproic acid, etc. So ketones, lactates, and uremic accumulation. Here we have a very good reason for the patient to have ketones, and they probably have diabetic ketoacidosis. So I'm going to ask my dear friends in the chat a challenge question. Can you name the 4 causes of ketosis? And we'll end with that. One of them is diabetes. What are the 3 other causes of ketosis? And with that, I will hand the mic back to Amanda to tell us what happened in this case.
So just explain the saturation, the low saturation. It's because the patient with ketoacidosis have a condition is the Kuzumaul respiration, breathe.
Yeah.
And this classical patient. And some points I want to say to everyone is when the patient have hyperglycemia, metabolic acidosis, and ketosis, we have always to think in ketoacidosis. Diabetes is the leading cause of morbidity and mortality in children and young people with type 1 diabetes. And the main etiology is infection, is irregular use of insulin, use of alcohol. So it's a disease that requires early diagnosis and treatment. We have always to think this as a differential diagnosis.
Beautiful. Amanda, thank you so much for bringing this case. You said it was simple, but in many ways, this is the medicine we practice. It's a very, very common issue. And the chat just had it from moment one. As soon as you said polydipsia and polyuria, they landed on Dka. And I think we learned a lot. We learned the rule of 2s, that you cannot make a diagnosis of abdominal pain on a history. And there are 2 exam things you can diagnose hernia and zoster, 2 bedside tests, EKG and post-void residual, and 2 labs. Ketones, as you just taught us now, and the lipase for pancreatitis. The rest need imaging. And here you reminded us of the importance of understanding Kussmaul breathing in a patient with diabetes. We learned about anion gap metabolic acidosis. And we'll end with a short list of the 4 causes of ketosis. I saw Karen was mentioning one. Karen, do you want to unmute yourself and explain what you were saying about alcohol?
Hey, hi everyone. Well, I have read about the the causes of ketoacidosis.
Yes.
And well, one of them was starving, the other one alcohol, and well, the most common in hospitals, the diabetic ketoacidosis. I didn't know any one of them, another one, so I only put the alcohol one because it's the first that I remember.
Beautiful. Your memory is very good. Now we named two. There's diabetes, there's alcohol. The chat also reminded us of starvation ketoacidosis. And the final one is very rare, but it is a glucagonoma. It is when you secrete glucagon from a tumor in your pancreas, and that completely suppresses insulin and causes ketosis. So your clue to the presence of a glucagonoma is the presence of ketosis in a patient who doesn't have diabetes, who doesn't have starvation or alcohol. Amazing. I saw that there was, I thought, Tuan, do you want to unmute yourself and tell us your question? It's a very, very good question to end with, a more practical note.
Yeah. Hi, everyone. I'm actually just a first-year medical student in America, in Penn State. So I just I found this podcast. I've been a fan since the last 2 weeks, and because we were taught of checking for delta, and sort of like the winters, and I just wonder about their actual practicality in clinical practice. So for every time that you get metabolic acidosis, the Winter's formula of like 1.5 times bicarb plus 8, and then you check for is the patient compensating appropriately with their respiration. And so it's sort of like give an insight into, all right, does all of like the ABG data make sense? And then for the elevated metabolic acidosis, you check for that delta ratio. The first delta is the delta between the gap, right? So normal gap is 12 from the the measure, and the second delta in the denominator would be the delta of your bicarb. And so then we check for that, all right, is the bicarb making sense with the patient's acidosis? And so the normal ratio is between 1 to 2. And so if you have something like greater than 1, I think, or less than 1, sorry, that it will be something like a concurrent, like HE metabolic acidosis. And then if you have something that's greater than 2, then you think a concurrent alkalosis, because you do have multiple pathologies going on at once, like diarrhea, vomiting, for example, is a classic example of that. But that's what I know so far about this.
You're like a nephrology professor. That was outstanding. Thank you so much for sharing that and for bringing it up today. All right, last but not least, Chiara, please take us home.
Hi, I love Tuan approach. I had an internal medicine professor that once told me all that, and was at first difficult to understand, but very useful. So some teaching points for today is our first approach of abdominal pain is that it's a very broad differential diagnosis. So two definitive diagnosis that we have to take into consideration is that with the exam we can determine if the patient have a hernia or zosters. Bedside diagnosis, if we take an EKG, we can diagnose myocardial infarction maybe, or with a post-void residue. We also can determine a urinary retention. Also, two labs we can take to determine if there is hyperglycemia, and other with amylase, an example, pancreatitis, yeah, or in kids or in adults. Then we had polyuria in this patient, and we received a great approach with if maybe this is an osmotic cause or non-osmotic cause, but also Ravi told us that we always have to think that maybe this patient drink too much water, so we have to think about that, and also distinguish polyuria with urinary frequency, which are different but maybe can be associated. Also, when we have abdominal pain with respiratory problems, as this patient, we have to think about diabetic ketoacidosis. However, there are also some differentials. In this case, this patient had a SpO2 in 79. That wasn't very likely for a diabetic ketoacidosis, but well, And then we had when we have an acute crisis of hyperglycemia, we have to distinguish if this is a diabetic ketoacidosis or a hyperosmolar state. So just like physiologically in diabetic ketoacidosis, we have zero insulin, and this is more common for Taiwan first presentation because they develop because there is no insulin, they develop ketones, and that's what we can find in the urine. However, in hyperosmolar states, we can find them in patients that are not well controlled, not commonly in children. So these patients still have insulin, so they can elevate their glucose very, very high, like Drew told that there is a world record. And well, also we have to think about all the triggers that can lead us to a diabetic ketoacidosis or hyperosmolar state. In the first choices, maybe there is an infection that triggers this. Also, again, in kids, the most common etiology is type 1 diabetes as first presentation, but in adults, the differential is very broad. And lastly, high anion gap metabolic acidosis. We have to think about three important things: ketones, so check it in the urine, lactates, if they're present or not, and uremia. And then we have to get creatinine and CK to see any other associations with this high anion gap metabolic acidosis. And lastly, not lastly, but at least in adults, we have to think about alcohol, and very rare, but we have to rule out too, is a glucagonoma. So this is the teaching point for today.
Absolutely brilliant. Thank you so much. And I think this is the perfect time to make a quick announcement. So next week, next Saturday, we are going to take the case and actually make it a podcast episode. And as you know, you can, for those of you who participate out loud, you can totally put the podcast episode on your resume so people can hear it and listen to it. So next time, whoever is willing to present a case, you'll be on the podcast, the main podcast platform. So anyone who wants to, first person to volunteer, their case will be heard on the podcast. And anyone who participates, like on the chat, like today, all the people who participate, if you speak out loud next week, make sure to put it on your CV. And we encourage all of you as much as you can in the chat to participate. The more people that participate, the more voices we hear from across the world, and the more we can celebrate our time together. So next week, have a case in handy if you do have one, and be ready to jump on it from the chat just like we did. And it looks like Hernan has a case. Amazing. All right, that would be wonderful. So Hernan, we'll count on your case next week. And you'll have to sing before you start. And guitar. All right, y'all. See you then, okay? Bye.
Bye, guys.